Hello, today we're going to talk about sensory processing, touch, and pain. This is Susan Guy, and I'm a psychiatrist. And let's go ahead and start the webinar. So, what is touch? Many different sensations blended together. The skin is a very complex organ that contains a whole bunch of different sensory receptors. And the dorsal column system carries somatosensory information from the skin to the brain. So here's some different types of bits of the sensory system, and there's mechanical, so touch, pain, hearing, vestibular, joint, muscle, visual, thermal, chemical, electrical, all sorts of different parts of the sensory system. And they have a restricted range of responsiveness. For instance, a frequency range of hearing, which varies with species. So here's an example of some differences between an elephant, cats, and humans. Elephants can hear low frequencies that humans cannot, and cats can hear high frequencies that humans cannot. And here you can see some differences between mammals, humans in particular, the black lines there, and birds and fishes. Each sensory system has a different sensory pathway in the brain and passes through stations during processing. And most sensory pathways do go through the thalamus. So that's a very important part of the brain for sensory perception. The sensory pathways then terminate in the cerebral cortex. So here you can see the information comes in through the sensory peripheral nerves, through the spinal cord, up to the brainstem, to the thalamus, and then to the primary sensory cortical areas, and then it's transmitted to other parts of the brain. So there's different receptive fields in the cortex. There's a separate primary sensory cortex, which exists for each modality. And then there's a secondary sensory cortex, or non-primary sensory cortex, same thing, that receives its main input from the primary cortical area for that modality. The primary somatosensory cortex, S1, or somatosensory 1, receives touch information from the opposite side of the body. So here you can see the central sulcus and the postcentral sulcus, and in between those two grooves is the primary somatosensory cortex. So that's the left side of the brain that would affect touch for the right side of the body. So there's an interesting representation of the body surface on the somatosensory cortex of the brain. So the bit there with the leg, foot, toes, and genitalia is kind of hanging down into the fissure between the two hemispheres. And then you can see from different areas on this somatosensory cortex strip, the part of the body where sensation is affected can give you an idea where the lesion is. There's something called the homunculus, which people talk about being in the brain. It's this little man that's sort of leaning over the edge of the brain. We'll go back here with his toes and legs kind of hanging over the middle part between the two hemispheres, and then his face over-exaggerated and hanging down lower. So there's different parts of the body that are overrepresented as far as touch, and those would be the face, the mouth, and the hands particularly. So the skin is what we use to perceive touch, and it has three separate layers: the epidermis, which is the thinnest outermost layer, the dermis, which is the middle layer and has the nerve fibers in it, and then the subcutaneous tissue, which anchors muscle and helps shape the body. It has fat in it and also senses vibration. So here you can see the different parts of the skin, with different types of cells perceiving different types of touch or different types of sensation. So there's some difference between what the book says and what may actually be going on. So the book says that the dorsal column system delivers touch information to the brain, but receptors send axons via the dorsal column of the spinal cord, where they synapse on the dorsal column nuclei in the medulla. And then axons from the neurons in the medulla cross the midline and go to the thalamus. This is sort of correct, but not entirely. So there's something called conscious proprioception or stereognosis. That is knowing where you are in space. And this does do that. But light touch is also represented in the spinothalamic tract. That is the tract that goes from the spine to the thalamus and that crosses over at lower levels. And that's why light touch is generally spared if you have a spinal cord lesion on the same side, as there are other routes to carry the information. Pain and temperature, however, cross over low in the cord, not at the level of the brainstem, and unconscious proprioception is where you can kind of tell where you are in space, and that's on the same side. It's ipsilateral and connects with the cerebellum. So here's some of the different somatosensory pathways here. Oops. Going from the spinal cord up to the thalamus and the cortex. And then we're going to talk about dermatomes, and that's a part of the skin, specific area of the skin that's innervated by a particular spinal root. And the boundaries of adjacent dermatomes overlap a little bit, so they're not exactly demarcated. And they're important because they can give you an idea of where a lesion is in the spinal cord, or of what type of pathology is going on. For instance, shingles causes a rash and pain that follows these different dermatomes. And that's where a form of herpes lies dormant in the nerve ganglia and then is activated in times of stress or immune suppression. And so if you see this rash and pain happening in areas demarcated by specific nerves, you can get an idea that it might be shingles. So there's different clinical landmarks too that you can learn about from the dermatomes. So for instance, the little toe is innervated by S1, and if that's impaired, that gives you an idea that the reason that you're having pain shooting down your leg, if it's going to the little toe, is because of sciatica. So here are the different dermatomes. You've got the cervical area, thoracic, lumbar, and sacral, and we'll see how that's represented on the human body, on the skin in a second. Here we go, cervical, thoracic, sacral, or lumbar and sacral. So going back, you can see where those parts of the spinal cord are represented on the dermatomes of the skin. And here we go again. This is just showing some important clinical landmarks. So for instance, you might want to know that S1, the lateral margin of the foot and the little toe, is innervated by S1, so that gives you an idea that there's sciatica, as we talked about before. Or say the person's incontinent or can't feel touch around their perineal area, then you know that S2, 3, and 4 may be affected. There's a quick mnemonic for that, which is S2, 3, and 4 helps keep the poop off the floor. So that's one of the things we learn to memorize all these different things. So if there's some numbness, say on the thumb, you know that this C6 or cervical area 6 is potentially involved. So it gives you an idea of what part of the spinal cord might be injured if there's a lack of sensation in a certain dermatome on the body. So cells in the somatosensory regions of the brain are arranged by body surface plan, and brain regions reflect the density of body innervation. So receptive fields can be changed by experience. The cortical map represents the innervation of a body region. If the nerve to a body region is severed, that cortical area or representation in the brain will shrink. So for instance, here's the representation in the brain of a hand. It's a monkey brain and a monkey hand. You can see that each digit is actually represented there on the primary somatosensory cortex. And if a body region is removed, that the cortical areas for adjacent body parts will expand. And if you stimulate a specific body region, then that will expand its representation on the cortex. So here there's stimulus with these particular digits, D3 and D2, really being stimulated And so that part of the brain that represents those digits actually takes up more space in the somatosensory cortex. Likewise, if there's an accident where part of the body is missing, the other adjacent parts of the brain, the representation for adjacent areas will expand the space that they take up in the brain. So for instance, there's a man who lost his hand when he was a teenager, and then when he was 35, he got a hand transplant from an accident victim. And then a few months later, his S1 map again contained representation of the hand. So it went away when he lost the hand, and then it came back when he got the transplant back. So here you can see the normal somatosensory cortex with the face, the hand, and the arm represented on S1. And that would be, of course, for the right side of the body. And then say the person loses their hand, what happens to the somatosensory cortex? Well, the adjacent areas, there we go, the adjacent areas for the face and arm get bigger. So some sensory fibers transmit touch information to the cortex, but others, like light touch ones, don't. And the light touch system is pretty interesting, and we still don't really understand it. It tends to activate the insula, cingulate, and medial cortex, so that's the core of the social brain, and it helps to support bonding, regulates emotion, and decreases stress. With light touch, there's an increase in endorphins, and that's kind of the endogenous natural opioids that we have in our bodies, as well as oxytocin, which is the bonding hormone, as well as dopamine and serotonin, some more pleasure hormones or neurotransmitters. And light touch causes a decreased blood pressure as well as mild sedation and decreases depression, irritability, and pain. So what about pain? When you're taking a history and you're asking somebody about pain, it's important to describe different aspects of it. So you don't just say it hurts when you're reporting that someone's complaining of pain. You have to describe what it's like. So is it throbbing, gnawing, or shooting? And it can help to identify the kind of pain or the source of the pain. So for instance, if it's a zapping, tingly pain, it might be a nerve type of pain. Whereas if it's a deep gnawing pain, it might be bone type of pain. The intensity, how bad is it? How long has it been there? Where is it? And what makes it better or worse? So there's different types of pain receptors. So let's look at some examples. Capsaicin, which is the chemical that makes chili peppers hot, has a receptor that binds it, which is called the vanilloid receptor. And this detects painful heat normally and is on a thin, unmyelinated axons that conduct slow, long-lasting transmission of perception of pain. There's the cool menthol receptor, which responds to menthol in cool temperatures. And then there's some other free nerve endings that respond to histamine and use gastrin-releasing peptide to stimulate neurons to provide a sensation of itch. So the anterior lateral or spinothalamic system transmits the sensation of pain and temperature, and free nerve endings synapse on spinal neurons in the dorsal horn of the spinal cord, the back part of the spinal cord. Pain information crosses the midline in the spinal cord before ascending to the thalamus. So here you can see that. Pain ascends the spinothalamic system to reach the brain. So it goes up the spine to the thalamus into the cortex. So peripheral fibers probably use glutamate, which is a general excitatory neurotransmitter, to excite the spinal cells in the dorsal horn, that is the back part of the spinal column and spinal cord. And they also release substance P, which is a neuropeptide, and that's going to be important to know about in the future because there's probably going to be some different medications to target pain that affect substance P in the future. Postsynaptic neurons take up substance P and remodel dendrites, which may affect pain perception. Neuropathic pain is a nerve type of pain. So it's when the pain is signaled by nerves and may signal that particular nerve has been damaged. And the dorsal horn neurons can become hyperexcitable and cause chronic pain. Chronic pain causes a much more rapid volume loss of the dorsolateral prefrontal cortex, which is not a good thing because that's part of our brain that we use for higher reasoning, inhibition, logic. So pain information is integrated in the cingulate cortex. How active it is corresponds to the subjective experience of pain, and it's going to be more active if people are led to believe that a stimulus is going to be more painful. So our perception or preconceived ideas about pain can actually make us hurt more or less. There are different subregions of the cingulate cortex that are activated if a person is experiencing pain rather than just empathizing with another person who's experiencing pain. So if the person themselves is experiencing pain, then the anterior and posterior cingulate are activated. And if they're just empathizing with someone who's in pain, the anterior cingulate, not the posterior cingulate, is activated. So some other terms, hyperalgesia is where people are more sensitive to pain. Analgesia is where people are less sensitive to pain, and that can be induced, for instance, by giving some local topical pain control medications, or by giving something more central like opiates that are drugs that control pain. And opioids are endogenous opiate-like peptides in the brain, so those are our natural opiates that we have. There are three classes of endogenous opioids. There are endorphins, enkephalins, and dynorphins. And opioid receptors respond either to the external drugs that we give, opiates, or our endogenous internal opioids that are natural within us. So serotonin also is involved with pain perception. There's input from the serotonergic raphe nucleus neurons that activate an opioid-releasing cell, which inhibits the pain signal from the spinothalamic tract. So if we have an intact serotonergic system and we're not depressed, we don't perceive pain as badly. And often people who are depressed are complaining of pain as well. There's sort of a vicious cycle there. And interestingly enough, medications used to treat depression that affect serotonin can also reduce pain. So caution should be taken when prescribing opiates for pain because of the risk of addiction, but it seems that mainly the people that get addicted to opiates are people who already have a predilection to being chemically dependent. Cannabis can also be an analgesic and works by stimulating endogenous cannabinoid receptors. And here we can see some different approaches to pain control. So there's placebo, which actually works quite well. Hypnosis and stress, cognitive behavioral therapy is something that's used in our pain clinic that has a good effect for a lot of people. So opiates aren't the only thing that are used to treat pain. There's spinal blocks. There's non-steroidal anti-inflammatory drugs like naproxen or ibuprofen. Then there's prednisone is sometimes used to decrease inflammation. Cannabinoids also useful. Acupuncture is also often used even in mainstream medicine for pain control. There are some surgical interventions, but those are pretty drastic. So a TENS unit delivers electrical impulses to the skin and works pretty well. Relieves pain by stimulating the nerves around the source of the pain. And interestingly, does something to endogenous opioids or the opioid chemicals that we naturally secrete, because if you give an opiate blocker, which is naloxone, a medication, that blocks the pain control or the pain effect induced by the TENS unit. So it's doing something to opioids in our bodies. A placebo can also help relieve pain, even though it's not actually a medication that should be working. And this probably also works by releasing endogenous opioids. And if you believe you have less pain, it causes less pain. Acupuncture also relieves pain by inducing an endogenous opioid, which is endorphin. And trauma can also cause numbing, which is a really nice adaptive response because it allows people to focus on getting out away from the danger instead of being paralyzed by pain. So here you can see a placebo acting to work on blocking some of those pain perceiving areas of the brain. So if we think that we're not experiencing pain, our perception of pain goes down. So social rejection also activates the anterior cingulate cortex, and the extent to which a person is upset by rejection is positively correlated with the activation of this region. So social hurt activates the same part of the brain as physical pain. And if you're less sensitive to rejection, there's less activation of the anterior cingulate. And this occurs in people who took Tylenol in one study. So Tylenol may actually decrease our sensitivity to social rejection. Interesting. So here you can see in the study, social distress, more social distress associated with increased activation of the anterior cingulate cortex, and people who were taking a pain medication had less brain activity during a period where they didn't feel included socially than people who were taking placebo. And this is interesting because I have had people tell me that they take opiates illegally in order to feel less anxious and more included socially. So that may make some sense there, but it's a very dangerous road to go down. So there's a lot of comorbidity with pain. Depression is near 100%. People, as we mentioned before, who are depressed report higher levels of pain. And poor pain control is going to happen unless you also treat the co-occurring major depressive episode. Chronic back pain increases the risk of depression 6-fold, and 44% of people with major depressive disorder also have a pain disorder. More pain makes somebody more likely to be severely depressed for a longer period of time. Pain causes depression, and depression causes pain. It's that chicken and the egg thing. Pain is also associated with anxiety, especially PTSD, with early childhood abuse, but other types of PTSD as well. Sleep deprivation, chemical dependency, all of these things are comorbidities with pain. And constipation is a comorbidity with pain because pain interferes with bowel peristalsis. So it actually makes you likely to get constipated if you're in pain because you have that fight or flight thing going on. But the other thing that's not good is that opiates and other pain medications, including tricyclic antidepressants, also cause constipation, so you've got a double whammy. So it's very important when you have a pain patient to make sure that the bowels are working. Can be really bad and result in obstruction and sometimes even in death if the GI tract gets plugged up. So depression and pain feed each other. You have to evaluate the patient for both, and you have to remember to treat both. And that's the end of this webinar. I hope you've enjoyed it and have learned a few things. Thank you.